Assalamu alaikum. Let's dive into gestational trophoblastic disease. Start with Hydatidiform mole and then Choriocarcinoma, very high yield topic of the USMLE exam. Okay, now before jumping into the box, I would like to say what is Hydatidiform mole or okay, HM Hydatidiform mole, previously known as molar pregnancy, MP. Molar pregnancy is a type of gestational trophoblastic disease characterized by abnormal there is abnormal villus trophoblastic growth. There is abnormal villus trophoblastic growth. There is abnormal villus trophoblastic tissue growth. Molar pregnancy, this is classified into a complete mole. It may be complete or it may be partial mole. Okay, what's this pathophysiology? In pathophysiology, early pregnancy formation requires maternal and paternal genetic contribution and a balance of maternal and paternal and a balance of maternal and paternal imprinting of for neonatal and placental development. Hydatidiform mole develops Hydatidiform moles develop from abnormal fertilization that result in excess paternally derived genetical material. Excess paternally derived genetic material which leads to abnormal placental trophoblastic proliferation. So, abnormal placental trophoblastic proliferation and impaired fetal development. Molar pregnancy is the most common type of gestational trophoblastic disease are considered as pre-malignant condition composed of genetically distinct fetal, not maternal tissue. It is classified into either complete or partial or incomplete mole, complete or partial or incomplete mole. Okay, if we go through the complete mole, the majority, okay, what happens in the complete mole? Complete mole occurs when an empty, complete mole occurs when an empty or no maternal genetical material, empty ovum fertilized with an sperm, empty ovum fertilized with a sperm. The chromosomes of the chromosomes from the haploid the chromosome from the haploid 23X sperm are then duplicated. It is then duplicated and form diploid 46XX tissue that contains only a paternal gene. These 46XX only that contains only paternal DNA. Less commonly, sperm fertilized with an empty ovum and can generate that can create either 46XX or 46. So it can create either 46XX or 46XY. Okay. These the abnormally genotype leads to abnormal proliferation of the placental precursor cell with no fetal development. The macroscopic appearance of complete mole is branch or bunch of grape appearance. You have to remember this word. If you find in a stem bunch of grape appearance, the think about molar pregnancy, think about hydatidiform mole, and in hydatidiform mole, in complete mole, it resembles as a bunch of grape appearance due to its edematous hydrophic villi and trophoblastic hyperplasia. Microscopic appearance reveals a large edematous with decreased blood vessel and decreased proliferation of the trophoblastic line. Decreased trophoblastic line. In addition, because all genetic material is paternal, complete mole stain negative for P57, a product of paternally stain negative for P57 protein, a product of paternally imprinted but maternally a product that paternally imprinted but maternally expressed gene. Is all the genetic material is paternal, so P57 is negative because this P57 protein is a product of a paternal imprinted but maternally expressed. As maternal genetical material is absent here, so it is negative. The excessive trophoblastic proliferation characteristics of complete mole leads to abnormally high beta-hCG level. In here there is abnormally the complete mole, there is abnormally high beta-hCG level, results in classic unique presentation that a markedly elevated beta-hCG level leads to the HOTE. What does it mean? HOTE. It abnormally high beta-hCG causes hyperemesis gravidarum. So if there is hyperemesis gravidarum, think one thing that it may be Hydatidiform. If there is overt hyperthyroidism, that means a shared alpha subunit between TSH and beta hCG stimulates T3 and T4. And think about theca cyst due to hCG or ovarian hyperstimulation and theca cell luteinization that secretes androgen and can cause acute hyperandrogenism like igneal hirsutism. It may be early onset PE with severe feature. So incomplete mole, as there is abnormally high beta hCG, so abnormally high beta hCG can comes with other feature, and think about it may be complete mole. And in incomplete mole, what happens in incomplete mole? The majority of incomplete or partial mole is normal ovum fertilized with two sperm, or rarely a normal ovum is fertilized with diploid sperm. So normal ovum fertilized with diploid sperm. So incomplete mole, the resulting partial mole has 69 triple X or XXY containing maternal or paternal DNA with extra chromosome set of paternal origin. Partial moles are unique as they are associated with presence of a fetus may exhibit with cardiac activity. These fetus may exhibit with cardiac activity because, however, because of the triploid karyotype, very high rate of intrauterine death occur, often manifest as spontaneous abortion. Early onset spontaneous abortion. Partially moles are distinct histologically from complete mole. Partial moles are distinct histologically from complete mole in that they have focal hyperplastic trophoblast and focally enlarged hydrophic villi. What are now? Now this box. What are its risk factor? Risk factor is extremes of age, less than 20, more than 35, less than 20, more than 35, previous molar pregnancy, like a history of Hydatidiform and previous, and another risk factor, previous spontaneous abortion or infertility. Clinical feature in here, clinical feature may be divided into early or late. Clinical feature may be divided into early or late. Early feature is like vaginal bleeding, like pelvic pressure, like uterine size is greater than the gestational age, uterine size greater than the gestational age, and hyperemesis gravidarum. And the late findings like hyperthyroidism, early onset preeclampsia, and theca lutein cyst and theca lutein cyst. If you remember the HOTE, like HOTE, that means high beta hCG features, then uh, you can get the clinical feature like H for beta hCG causes HOTE hyperemesis gravidarum can happen. Hyperemesis gravidarum can happen. There may be overt hyperthyroidism features of the overt hyperthyroidism like palpitation, diaphoresis, heat intolerance, hyperemesis gravidarum, and theca lutein cyst due to beta hCG overstimulation with luteinization of the theca cell, and there may be early onset preeclampsia due to abnormal spiral artery development leads to hypertension and proteinuria less than 20 weeks. Hypertension and proteinuria less than 20 weeks, and the other feature like pelvic pressure can happen. Now the diagnosis. In diagnosis of the hydatidiform mole, if you want to diagnose the hydatidiform mole, physical examination, labs, there is no storm appearance on ultrasound, quantitative beta hCG level, and histologic evaluation of the uterine content. Histologic evaluation of the uterine content. Okay. Okay, for diagnosis, three things: snowstorm appear on the ultrasound, quantitative beta hCG level, and histologic evaluation of the uterine content. If beta hCG is more than 1 lakh, if beta hCG is quantitative serum beta hCG is more than 1 lakh, think about hydatidiform mole and histologic evaluation of the uterine content. Management is dilatation DNC, dilatation and suction curate serum, serial serum beta hCG post evacuation and contraception for 6 months. Look at these flowchart, very high yield flowchart. Management of hydatidiform mole, suction curettage, weekly beta hCG level until undetectable. If it is increasing or plateauing, diagnosis of gestational trophoblastic neoplasia. If it is decreasing, monthly beta hCG level at for 6 months, beta hCG level are undetectable, surveillance complete can attempt pregnancy. Surveillance complete can attempt pregnancy. So suction curator should be done. Then weekly beta hCG level until undetectable. If it is increasing, diagnosis of gestational trophoblastic neoplasia. That means choriocarcinoma may happen. If it is decreasing, if weekly decreasing, then monthly for 6 months. If monthly decreasing, then beta hCG undetectable. If monthly beta hCG becomes detectable, then again think about diagnostic trophoblastic neoplasia. If it is undetectable, surveillance complete, can attempt pregnancy. What are its differential? Its differential uh, the DD of hydatidiform mole is threatened abortion, missed abortion, threatened abortion, missed abortion, and ectopic pregnancy. Threatened abortion, missed abortion, and ectopic pregnancy. Okay, okay, now choriocarcinoma. The gestational trophoblastic neoplasia, choriocarcinoma, risk factor hydatidiform mole and maternal age more than 40. There is vaginal bleeding, pelvic pain or pressure, increased beta hCG level, and metastasis. Vagina or lungs. There may be metastasis on vagina or lungs, and evaluation: pelvic ultrasound, X-ray, pelvic ultrasound, chest X-ray, thyroid function, uh, hepatic function, hepatic function, renal function should be done. Treatment is chemotherapy and hysterectomy should be done. Chemotherapy and hysterectomy should be done. What is the likely diagnosis in a 6-month postpartum woman? That presents with irregular 6-month postpartum patient can comes with irregular vaginal bleeding, enlarged uterus, irregular vaginal bleeding, enlarged uterus, dyspnea with multiple infiltrate on chest X-ray. Think about choriocarcinoma, irregular vaginal bleeding, enlarged uterus, dyspnea with multiple infiltrate on chest X-ray. Think about choriocarcinoma. Classically occurs after complete hydatidiform mole, after but can occur after normal pregnancy or spontaneous abortion. Okay, okay. Now look at question number one. In one, this patient look at the stem. Okay, physical examination: enlarged uterus, closed cervix, and minimal dark blood in the vagina. Chest X-ray: multiple bilateral infiltrate of a different shape. What is the most likely? Uh, what is the most likely would be helpful for establishing the diagnosis. So this patient has chest pain and dyspnea for 10 days. Chest pain and dyspnea for 10 days. There is spontaneous vaginal delivery. She has spontaneous vaginal delivery 3 months ago. Now there is dark bloody vaginal discharge. Dark bloody vaginal discharge. The most recent episode was 6 days ago, and there is no fever cough. So she has spontaneous vaginal delivery 3 months ago, but now she has bleeding, enlarged uterus, closed cervix, and there is chest X-ray. There is multiple bilateral infiltrate. So it looks like gestational trophoblastic disease. So do quantitative beta-hCG level for diagnosing choriocarcinoma. The because these choriocarcinoma can metastasize to the lungs and can cause this multiple bilateral infiltrate on various shapes. So, so chemotherapy should be given. And so choriocarcinoma is gestational trophoblastic neoplasia, a malignancy that arises from placental trophoblastic disease. There is irregular vaginal bleeding, enlarged uterus, and it is placental metastasis comes with chest pain and dyspnea. When choriocarcinoma is suspected, quantitative beta-hCG level helps to confirm the diagnosis. Look at this stem. Menstrual period 10 weeks ago. Small, mm, some brown vaginal discharge, pelvic pressure. Okay, look here. The patient was undergoing infertility management, very high yield. Yeah, a patient is undergoing infertility management. Mm, A bedside ultrasound, pelvic ultrasound show enlarged ovary, enlarged uterus filled with heterogeneous mass composed of cystic structure, and urine beta-hCG is positive. So do suction curettage for Hydatidiform mole. So treatment of Hydatidiform mole is suction curettage. Suction curettage should be done. So if there is a uterus filled with heterogeneous mass composed structure and urine beta hCG, urine beta hCG is positive, and there is pelvic pressure, think about Hydatidiform mole. So suction curettage should be done. If we look at this question, there is heavy vaginal bleeding, her last menstrual period 4 months ago, there is irregular spotting. Earlier today, this patient have increasingly heavy bleeding with passage of clots. There is hypertension, BMI is higher. Pelvic examination show moderate amount of blood in the vaginal vault. Bimanual examination reveals an enlarged uterus at the umbilicus. Fetal heartbeat is unable to identify Doppler. Serum beta hCG level is elevated. So looks like Hydatidiform mole, because one of the differential is ectopic pregnancy. Ectopic pregnancy can come with light spotting vaginal bleeding, but in here bleeding is chronically increased. There is heavy vaginal bleeding and features of overt hyperthyroidism, elevated beta hCG, enlarged uterus. There is overt hyperthyroidism. elevated beta-hCG, and enlarged uterus looks like Hydatidiform mole. And risk factor of Hydatidiform mole is vitamin A deficiency, Y surgery, raw and Y surgery, and extremes of maternal age. Patients age more than 40 with Hydatidiform mole are at increased risk of severe complication. Okay, look at this question. Pelvic ultrasound, uterus filled with multiple small cysts but no embryo. Multiple cysts, no embryo. Think about Hydatidiform mole. There is multilocular cystic appearance. Urine beta-hCG is positive. So it may be due to ovarian hyperstimulation from abnormal trophoblastic proliferation. Ovarian. So it may be due to theca lutein cyst, the HOTI, hyperemesis gravidarum, ovarian overt hyperthyroidism, theca lutein cyst, and theca lutein cyst. And another is like theca lutein cyst, and another is early onset preeclampsia. So it is theca lutein cyst. So this patient has intractable. Look at this patient. She has the patient is unable to tolerate oral intake for last 2 days. So hyperemesis gravidarum unable to take. So this patient has intractable nausea, vomiting, enlarged ovaries. Enlarged uterus. There is a revealed and enlarged uterus, and 13-week size and bilateral enlarged ovaries. So a concerning of complete hydatidiform mole. A complete hydatidiform mole. A complete hydatidiform mole is a gestational trophoblastic disease resulting from abnormal proliferation, empty ovum, either two sperm or by one that subsequently duplicates its genome. Markedly elevated beta-hCG. Beta-hCG and LH are structurally similar. The elevated hCG causes hyperstimulation of the ovary, hypertrophy, and luteinization of the theca cell. Um, as a result, the ovary from theca lutein cyst, ovary from theca lutein cyst, which are large and bilateral and multilocular, the theca cells secrete androgen and leading to acute hyperandrogenism. Theca lutein cysts are expectantly managed as they resolve after treatment of the hydatidiform mole by suction curettage and or hysterectomy when beta-hCG level decreases. So hydatidiform mole, a gestational trophoblastic disease, can present with theca lutein cyst. This theca can present with these theca lutein cyst. It is multilocular, bilateral, and 10 to 15 centimeters in ovary. Okay, look at this question. A 38-year gravidarum suction curettage is done. Any suction curettage is done. The patient initially presents 7 weeks after her last menstrual period or initial prenatal. At that time, she has breast tenderness. Okay, pregnancy symptoms, but empty gestational sac. Beta-hCG is very high. Think about hydatidiform mole. So it is hydatidiform mole. Okay, and then diagnosis done. But pelvic examination show minimal dark blood in the vaginal vault and no active bleeding. On bimanual examination, the uterus is small and non-tender, and no adnexal mass is palpable. Beta-hCG level is now 1412. What is the following step in the management of this patient? So his beta-hCG level is going down. So uh, we should do contraception for at least 6 months. So we should do contraception for at least 6 months. So hydatidiform mole, abnormal fertilization, gestational trophoblastic disease, surveillance of the development of the gestational trophoblastic neoplasia, and therefore during the surveillance period, contraception during the surveillance period, like we are doing weekly beta-hCG, then monthly. After surveillance complete, she can attempt for pregnancy. But in this surveillance patient, contraception is required so that a new pregnancy does not cloud the diagnosis and treatment of our gestational trophoblastic disease. Gestational trophoblastic disease. Okay, look at this question. In this question, there is bilateral 3 plus deep tendon reflex in the patella. Sustained beta-hCG level is elevated. There is features of headache, abdominal pain. So these are occipital headache. Okay, uh, not removing by acetaminophen. Okay, blood pressure is high. So in HOTI, like hyperemesis, gravidarum, over hyperthyroidism, thecal lutein cyst, and early onset preeclampsia. Early onset preeclampsia with severe features presentation and beta-hCG level is elevated. Looks like Hydatidiform mole. So hypertension, hyperreflexia, and elevated beta-hCG level concerning for preeclampsia. But this patient symptoms of early preeclampsia less than 20 weeks require an evaluation of abnormal pregnancy as so early onset preeclampsia less than 20 weeks of gestation. Think about Hydatidiform mole. Okay, last in this picture, just looking at this picture, there we can diagnose that this is molar pregnancy Hydatidiform mole. This is cluster of grape appearance, multiple cyst, enlarged placenta, gray cluster of grape appearance, and in here there is markedly elevated beta-hCG more than 1 lakh. Additional ultrasound finding like thecal lutein cyst can come. Okay, that's all about Hydatidiform mole and choriocarcinoma, a high-yield topic of gestational trophoblastic disease. Hope you enjoyed.